Musculoskeletal pain is a widespread health issue that affects millions of people globally. It involves discomfort or pain in muscles, bones, joints, and connective tissues, often leading to temporary or permanent limitations in movement and daily activities. This pain can significantly reduce quality of life, limit social participation, and increase the economic burden on individuals and healthcare systems. Despite advances in medicine, managing musculoskeletal pain remains a challenge due to its complex nature and the variety of conditions it encompasses. In this video, we'll explore the current challenges in pharmacotherapy for musculoskeletal pain and highlight the unmet needs in this field. Musculoskeletal pain is the most common type of pain experienced worldwide, according to the International Association for the Study of Pain. Conditions like low back pain, neck pain, and osteoarthritis are leading causes of disability. For example, low back pain alone affects about 7.5% of the global population. The prevalence increases with age, but it can affect people of all ages, including children and young adults. Risk factors such as aging, sedentary lifestyle, smoking, low income, and mental health issues further contribute to the burden. The impact is not just physical. Musculoskeletal pain can lead to social isolation and economic hardship. Classifying musculoskeletal pain is a complex and evolving process. The International Association for the Study of Pain identifies three main categories: nociceptive, neuropathic, and nociplastic pain. Nociceptive pain is linked to tissue damage and is often sharp and well localized. Neuropathic pain arises from nerve dysfunction, presenting as burning or tingling sensations. Nociplastic pain results from altered pain processing without clear tissue damage. Additionally, mixed and idiopathic pain types are recognized in the literature. Accurate classification is crucial for selecting the most effective treatment strategies and understanding the underlying mechanisms of pain. Diagnosing musculoskeletal pain can be challenging because it often involves correlating complex physiological mechanisms with the patient's subjective experience. Chronic pain, in particular, may not always be linked to visible tissue damage or a specific disease. The new ICD-11 classification helps distinguish between chronic primary and secondary pain, but practical application can be difficult. Chronic primary pain is considered a disease in its own right, while secondary pain is linked to other conditions. This distinction is important for treatment planning, but it can sometimes lead to confusion or even stigmatization of patients. Additionally, the mechanistic approach to musculoskeletal pain focuses on identifying the biological cause and targeting it with specific therapies. However, this model often overlooks the psychological and social dimensions of pain. The biopsychosocial model integrates these factors, recognizing that pain is influenced by emotions, mental health, lifestyle, and social context. This holistic approach is increasingly recommended for managing chronic musculoskeletal pain as it allows for more personalized and effective treatment plans. Combining both models can help address the multidimensional nature of pain and improve patient outcomes. World Health Organization's analgesic ladder is a widely used framework for managing pain, including musculoskeletal conditions. It consists of 4 steps, starting with non-opioid analgesics for mild pain, then adding weak opioids for moderate pain, and progressing to strong opioids and minimally invasive interventions for severe pain. The goal is to use the simplest and safest treatment at the lowest effective dose for the shortest duration. However, moving up the ladder depends on the patient's response and the intensity of their pain. This approach helps guide clinicians but also has limitations, especially in chronic pain management. Acetaminophen, also known as paracetamol, is commonly used for mild to moderate musculoskeletal pain. It works mainly in the central nervous system to reduce pain perception. While it is widely prescribed, especially in older adults, its effectiveness in chronic pain is limited. Recent studies suggest it may be more suitable for acute injuries rather than long-term conditions. Safety concerns, particularly regarding liver toxicity, mean that it should be used with caution, especially in patients with liver disease. Despite its limitations, acetaminophen remains a first-line option when NSAIDs are contraindicated. Nonsteroidal anti-inflammatory drugs, or NSAIDs, are cornerstone in the treatment of musculoskeletal pain, especially for conditions like osteoarthritis and low back pain. They work by reducing inflammation and are effective for both acute and chronic pain. However, NSAIDs carry risks such as gastrointestinal bleeding, cardiovascular events, and kidney damage, particularly with long-term use. Topical NSAIDs offer pain relief with fewer systemic side effects and are recommended for localized pain, such as in the hands or knees. Patients should be carefully monitored, and the lowest effective dose should be used for the shortest possible time. Opioids are reserved for moderate to severe musculoskeletal pain that does not respond to other treatments. While they can provide relief, their effectiveness for chronic pain is limited, and they come with significant risks including addiction, respiratory depression, and other side effects. The classification of opioids as weak or strong is debated, as all opioids carry the risk of misuse. Guidelines recommend opioids only when absolutely necessary and after careful assessment of the patient's risk factors. Non-pharmacological therapies and other medications should be considered first whenever possible. Adjuvant therapies include a variety of medications that can enhance pain relief when standard analgesics are not enough. These include antidepressants, anticonvulsants, muscle relaxants, and topical agents like lidocaine and capsaicin. While some Ativan's are effective for neuropathic or mixed pain, evidence for their use in musculoskeletal pain is often limited. Many are prescribed off-label and can have significant side effects. For example, antidepressants may help with chronic pain and psychological symptoms, but their overall benefit for musculoskeletal pain is modest. Careful patient selection and monitoring are essential. Some patients, minimally invasive procedures can offer targeted pain relief with fewer systemic side effects. These include injections of corticosteroids, hyaluronic acid, or local anesthetics directly into joints or soft tissues. Other techniques, such as nerve blocks or radiofrequency ablation, may also be used. While these procedures can be effective, they require specialized training and carry risks such as infection or local tissue damage. They are best used as part of a comprehensive treatment plan that includes both pharmacological and non-pharmacological therapies. Research into new therapies for musculoskeletal pain is ongoing. Promising approaches include nerve growth factor antibodies and racinoferratic, which target specific pain pathways. While early studies show potential for significant pain relief, concerns about safety and side effects have limited their approval for widespread use. Ongoing clinical trials aim to clarify their role in chronic pain management. As our understanding of pain mechanisms grows, future treatments may become more targeted and effective, addressing the unmet needs of patients who do not respond to current therapies. Placebo effect plays a significant role in the management of musculoskeletal pain, especially in conditions like osteoarthritis. Placebo responses can account for a large portion of pain relief, influenced by patient expectations, the therapeutic environment, and the doctor-patient relationship. Conversely, the nocebo effect, where negative expectations lead to worse outcomes, can reduce treatment adherence and effectiveness. Understanding these effects is essential for clinicians, as they can impact both clinical trials and real-world practice. Ethical considerations limit the use of placebos in practice, but harnessing positive contextual factors can enhance treatment outcomes. Given the complexity of musculoskeletal pain, a one-size-fits-all approach rarely works. Personalized treatment plans that combine pharmacological and non-pharmacological strategies are recommended. This may include medication, physical therapy, psychological support, and lifestyle modifications. Shared decision-making between patients and healthcare providers is crucial to balance the benefits and risks of each therapy. By considering individual preferences, comorbidities, and psychosocial factors, clinicians can develop more effective and satisfying treatment plans. Musculoskeletal pain remains a major challenge for patients, clinicians, and healthcare systems worldwide. While pharmacotherapy is a key component of management, it is often insufficient on its own. Integrating biopsychosocial approaches, considering placebo and nocebo effects, and personalizing treatment plans are essential steps forward. Ongoing research and emerging therapies offer hope for more effective and safer options in the future. By addressing the unmet needs in musculoskeletal pain management, we can improve quality of life and outcomes for millions of people.